And it's my pleasure to introduce our two federal partners. Captain Michael King is a social worker and epidemiologist who served at the intersection of behavioral health and public health for over 15 years. Dr. King is our regional administrator of Samsa, the Substance Abuse and Mental Health Services Administration. Prior to joining Samsa in 2019, he supported state and federal public health capacity at the U.S. Centers for Disease Control and Prevention as an instructor and field supervisor for postdoctoral fellows enrolled in the Epidemic Intelligence Service. Captain King previously served for 10 years on the National Asthma Surveillance Team in the National Center for Environmental Health, where his interests focused on chronic disease surveillance, environmental exposure, and hazard assessment and disaster mental health. As a commissioned officer in the U.S. Public Health Service, Captain King deploys routinely following disasters and has had the privilege to lead one of 5 national mental health response teams, Team 5, that provide crisis counseling and technical assistance to medically underserved populations with a focus on emergency health, public health response, and very timely work for what we might anticipate, what we actually have experienced in Tennessee lately. And I expect Dr. King will speak to that some during his talk. I got to actually talk with him for the first time recently, and I think we had an instant connection. Look forward to continuing working with you. I got to meet Betty Ann Bryce, I guess, last summer, and in Indianapolis, and we again another person that we made a very quick connection, and actually I was privileged for Betty Ann to come and join and observe our work in our 4th Judicial District, which is rural and suburban mix, but she has an extreme passion for helping people that live in rural environments. But to read her more formal bio, Betty Ann Bryce currently serves as a special advisor and rural lead in the Public Health Education and Treatment Group for the White House Office of National Drug Control Policy. She joined the ONDCP from the U.S. Department of Agriculture, where she served as senior policy advisor in the Rural Development Agency. Prior to joining the U.S. government, she served as the senior policy analyst for the Rural and Regional Unit at the Organization for Economic Cooperation and Development. In this capacity, she assessed regional and rural government policies in different countries and contributed to several OECD publications. Both of our federal panelists are extremely gifted and talented, and I hope you please join me and welcome them to our conference this afternoon.
Good afternoon. Thank you for the invitation, Judge Slone, and I go way back now. And thank you to the university for having me today. I should confess and say I'm all rural all the time. So I've been doing rural work for almost 20 years now, and so it is a passion of mine. And when I was asked to help out on the addiction crisis, it was easy to make that switch because from our perspective, what we were told is that it's really our mission at Rural Development is to build prosperity in rural communities, and you can't build prosperity if you're losing your workforce to addiction. So that's the area that I start from. And I wanted to, I don't know if the doctor is still here, but when he was talking about Krispy Kreme, I remember when I was going down the highway years ago and I saw the sign for Krispy Kreme and I turned around and went to get it, and I realized I understand now where the craving came from. So thank you for that. I want to start with just saying at the federal level, my role in the White House Rural Policy Office is pretty simple. Everyone, all the agencies, Dr. King represents the Health and Human Services, they're all very much so active. They are out there doing all the work. We came in to bring the rural voice and the rural perspective to it. So not to change anything, to work alongside. And I feel like my actual job is to say, how does this impact rural? how do you see this working in rural is what I would say I bring to the discussion when I'm talking to the Department of Justice, anyone, it's pretty much my role. The guidance that we get, or what sets the work for at the federal level, is the National Drug Control Strategy. If you haven't seen it, it is about roughly 20, 25 pages. It's pretty simple. Prevention, treatment, and recovery, and reducing the supply of drugs. We, as the federal family, should be setting our directives around the strategy, and we are working to do that. What we do in the office is to see how rural fits within the different pillars of the strategy and how it's being implemented, not just across my mother agency, which is the Department of Agriculture, but more broadly, how we can help our federal partners think about rural. So to give you the background of why the judge asked me to speak to you today, when we were invited to the table to think about this, we decided to have a group conversations with rural, because we don't want to presume or speak for rural. We want to hear from themselves what's working, what's not working. So we had announced 5 local conversations, roundtables in communities, population less than 50,000, to say, hey, what's going on, please tell us. We announced 5, we ended up doing 25. And we heard quite a bit. The difference between our agency and our federal agencies is when USDA has a roundtable, everybody in the community comes out. So if DOJ has a conversation, you get the DOJ folks, you get everyone. When we have a roundtable, the farmers are there, every employer is present, every actor in the community is present, and the reason why is my agency is the only agency in the federal government that can rebuild a community from the bottom up. So our money is in housing, our money runs the water systems, our money runs the electric systems, our money runs the businesses, and that actually means that our stakeholders is the community, because that's what we do. So what was different about our roundtable was that we had folks who had been very active and folks who had not at all been engaged so far in this crisis. And we got a mouthful and we got an earful. What we decided to do was take that information and say, what were the 2 things we learned from this? The 2 things we learned was, first, I don't understand the issue. That was consistently what we heard from every community, and I don't know where to go for funding and for resources. So we took that back and said, I think USDA can help with that. And so what we tried to do is, the first response was this one. If I'm going in my, oh wait, what? Okay. Oh, there you go. So what we did was look around for whatever was a product. We don't believe in rebuilding anything. We decided that we needed to look around and find something that was already out there, that was available. So I won't bore you with just how many data tools were presented to me to get to this one. But this tool was created already. It was for the Appalachian region. And we looked at it and thought, could you do more with it, and could we make it more rural focused? And again, when I say rural focused, urban is in there as well, but I default to rural as my job. But everything I say, we can't just put rural data in anything. So what we tried to do was say, how can we break down the CDC data, all the data that everyone is talking about, into like bite-sized chunks for everyone to take advantage of, every coalition, every task force, big or small. Can you use it? How are you using it? And what information do you need? So we asked NORC, an amazingly brilliant research institution, to work with us on this task, and this was the tool that they created for us. And I'm gonna just walk you through it just a bit, because I wanted to show you the way we designed it is very helpful to everything that everyone is doing today. The first thing we looked at was, okay, when you open the tool, this is what you see. Again, pretty simple. We deliberately kept it simple. We did not break down the data by year to year because we did not feel that was particularly relevant for rural. Again, that was our perspective, so we gave it in 5-year tranches. And what you can see, and the reason we wanted to do that is to keep it simple, and so a community can see what is happening at the rural county level. So we took the CDC data, because normally when you look at it, you just see kind of the state is that color. We broke it down by county. And again, this is the data everyone is using. Then if you look up there, we have all drugs, deaths, or opioids. Again, 2008 to 2012, 2013 to 2017, again, keeping it in 5-year tranches. So you can kind of see pretty much, am I going up, am I going down, am I holding steady? And we broke it down by county, but you can also see the information by state. And again, you can click on it, rural, urban, and then we have overlays for tribes, tribal communities, if you want to do an overlay to see where the tribes are relative to the challenges. I promise you I'm moving. So what I wanted to show you again, like I said, you can see all drugs versus prescription drugs, versus where you're advancing when it's just opioid-related deaths as reported versus all drugs. And I wanted you to just see how you can look at that progression if that is indeed something you're interested in, and then all drugs. And I took Tennessee to put it up there so you can see kind of your movement over the last 10 years, if that is indeed something. But what's really valuable about this tool is, at the end of the day, you're color coding. Who's getting darker, who's getting lighter? Because at the end of the day, that's what you care about, because that is who you should be talking to, who you should be learning from, who you should be, what are they doing? What should I be doing? This is, again, something to just add to the conversations that you are already having with each other. Again, if you click on the tool, you'll see to the left that you have the counties. You can click on the county to go to drill in, and when you click on that, you get more information. But what I wanted to show you is what I was kind of saying. Like, if you wanted to know, okay, who's not moving, who's holding steady over that period of time? And if you look at the difference, you kind of get the sense of what I'm talking about. It's pretty simple, but it's really good. So why is this particular, why are these counties over the last 10 years unaffected? This tool makes no analysis. It just really breaks down the data, and if it raises questions, you can go out and get those answers. Who's trending up? See what I mean? 81 to 102. What's happening, or what's going on there? Because again, as you heard all day, this is about partnership and collaboration. So it doesn't mean that people aren't working, but if we're doing prevention, but we're missing gaps, you're gonna not see the results that you're thinking you should see. My favorite group, again, picking up some other counties just so you can see, again, the variation. This is a pretty simple tool. Everything I showed you, it's intuitive. But we should be thinking about who's trending down. Now, when I was looking at Tennessee to see who was trending down, it's harder to see. But I wanted to show you, just if you look at 28 to 12, what's going on in that particular region? What are their policies, programs, initiatives, enforcement, partnerships, things of that sort? I mean, I would be loving to have some conversations here, because that's really, from a numbers point of view, that's movement. Same thing with Granger County. So you have good news. I mean, it's not all bad news. This is all just information that helps you in your work. I wanted to also show you some of your neighbors. If you want to talk about areas that have been hard hit, like yourselves, who are also showing progress. Look at that drop from 150 to 100 in Pike County. I'm sure there are some reasons for that as well. So this tool is really good for just showing you again what's going on in your neighbors, and maybe who you should be talking to to find out why they've shifted so much in over the time. The other thing about this tool, and this is important because I've heard it said today, in rural communities, this issue is about economic distress. It's in urban areas, it's about supply. In rural areas, it's about economic distress. So you really need to understand just a bit more about what are these correlating factors that are driving this. If you're not fully on board with that thinking, the data will help you get there. And so what we try to do with this tool is add more overlays for you to see if there's a correlation. So I just did 2 in the interest of time, but look at unemployment. It kind of speaks for itself. There are some indications, and if you look at poverty. So it's not going to surprise you that the areas with the highest unemployment, highest poverty, intergenerational long-term poverty, persistent poverty, there are correlations. So the idea is if you're crafting your policies and your responses and you're not picking up the underlying factors beyond ACEs that are driving what's happening in communities, you may still be in this situation in 5 years, in 10 years. So it's very hard, and if these actors are not at the table when you're having your coalition meetings and your discussions, that's a missing person. Economic development stakeholders are a different group of people, and that's who should be helping with the housing stakeholders. In rural, we believe firmly that the table should be crowded. Planning is there are planners in your rural transportation, is a different group of folks. So when you are having this discussion, and I know it's triage and I know people are dying, but you're rebuilding communities from the ground up. You're rebuilding communities. So it's harder to do prevention, treatment, recovery without taking into account long-term economic distress and disadvantage that is driving a lot of what's happening. The other thing that we did to answer the second question we had was, where are those resources that can help? Federal government has resources, everyone has their lane. Department of Justice, if you are inclined to go there. I spent 2 days, by the way, with police chiefs yesterday, 25 police chiefs and me. So this presentation is
2 days yesterday?
Yeah, 2 days, Monday, Tuesday and Wednesday, with police chiefs, rural police chiefs, by the way, quite chatty. So everyone wants to know about where resources are. And so what we decided to do was help them think about it and put it all in one place. And what did we do? We brought federal agencies together and we said, where is the money that can directly or indirectly help rural communities? Now, the reason why we framed it as directly and indirectly, and that's important, when you say direct resources, you get public health and you get DOJ to the table. When you say indirect, you get the Department of Commerce, you get Small Business Association, you get the FCC, you get the Department of Transportation, you get EPA, you get all the other agencies that maybe you are not thinking about who also have resources that are supposed to be working in communities. Again, I'm always going to stress this. Rural demands a bigger group of stakeholders to the table. Success will not work without some of these hidden actors. So one of the reasons we did was we got them all in the room, and I'm doing the same thing that you did. USDA was not part of the crisis agency. That's not what we do. But when they asked us to look at rural, we said some of the people we need for rural are not here. So we had to kind of go in and kind of bring some of those actors together. And so we formed an interagency IWIG. It's a working group for federal agencies. I co-chaired it with someone. That was a lot of work because you're bringing agencies that normally don't think rural to the table. We met twice a month. I know, it was painful, for 6 months to develop this PDF That is a whopping 153 pages of information in one place with live links for everyone to take advantage of all the resources that can help. Now, of course, again, I default to rural, but a lot of these agencies don't think rural, so a lot of the information is basically urban programs that are also for rural. But if you don't tell rural it's for that they can apply as well, guess what? They don't apply. And this is something we've been learning quite a bit. So it's a pretty simple tool. As I said, it's came out last year. It was rough. We wanted to get something out because the rural communities were not applying. I know everyone talks about resources, but you get data and I get data. And I can tell you that communities under 50,000 are the lowest number of applicants across the United States, across every agency. They're not applying, they're not taking advantage of the resources. Whatever reason that is, there are a number of different reasons for that. So one of the reasons why this was so important was to put it all in one place. If they don't know where to go, now they have a PDF. We put it as a PDF because we know broadband is inconsistent. So that way you can print it, circle it, and when you get to a point, you can kind of get to know, be familiar with it. What is in here is we came up with a rudimentary, because we wanted to get it out, table of contents to give you a sense, tribes, everything, and you click on the links, the agencies are in there, and you saw the agencies that participated on the back. We're in the middle of updating this. This is live and it's available and the link is live. We're updating this and we're doing one of the things because we love rural so much, we're turning it into a website. So when you click on the link, all the agencies that can give you an ambulance, all the agencies that can build a clinic for you, all the agencies that are working on your infrastructure, all the agencies that are doing anything you need them to do, that rural can take advantage of. And the difference is, because of the love fest that I know everyone has with grants.gov, it's going to be designed to be rural friendly, rural user friendly. That's basically the mandate we gave them. The contractors started working on this a month ago. We expect to have a prototype ready by November and for it to go live by January or February. These are two of the things that we could help rural communities with. We feel that this works well alongside everything that you are doing, and it just gives you a place to go to kind of understand who's out there and what that can help, and hopefully marry it with what's happening at the state level, and then go forward with looking at private sector help. The other thing we're doing for the first tool that I didn't mention that's relevant for you is we're also going to add 5 new overlays. Where are your broadband access sites? If people keep saying that telehealth is going to change rural America, you need to know where broadband is inconsistent. We're also adding rural transit access maps. Everyone talks about transportation. When you like to see where those gaps are, because that could help you direct some of the decision-making that you're doing. Where are those health professional shortage areas? Keep hearing about those. Would love to see those overlaid. And where are those approved Samsa Locator sites? Because rural communities, they're traveling upwards of 60 to 100 miles to get to treatment. When you understand and see that visually, that helps you to think about how that is exacerbating and taking away from all the good work that you're doing if folks can't get to and from where they need to go to be responsive to all the amazing work that I heard here today. The last thing we're thinking about adding to this, and I think it's important for you to think about, is that intergenerational poverty piece. So USDA has a data point that is persistent poverty. So if you've been poor 20 years or greater consistently, imagine what that does to that overlay when you add just that. Because again, if you're just doing prevention and treatment in an area with high intergenerational poverty and 0 to 0 jobs, you're gonna see all those lovely clients again, and you're gonna keep seeing them. That's kind of the idea of just using the simple data. So I just wanted to give you, I won't go into this, but again, one of the other things that I run from the office, I don't spam anyone. If you want to be on the list, feel free to email me, is rural folks tend to miss opportunities. So I usually do a listserv at least 3 times a month where I give them a sense of what's going on and funding that's available. And I'm also giving you a sense of what rural communities have been able to do across the federal government once we started to give them a sense that you can go to DOJ, you can go to couple of other places to get funding, and also USDA, which it turns out a lot of folks weren't even using my mother agency to help them because they didn't know we did ambulances and we build clinics and we do all these really interesting things that could supplement some of the other resources that you have. So it's just about education. So I'm sure you'll get these slides, and this is an example of one of the last listservs that I sent out, and I just want to give you a sense of all three of those are transportation opportunities. Everywhere I go, people say transportation is a challenge. Those opportunities were all open from the Department of Transportation to help rural communities address their transportation. Those are all grant opportunities. So again, the federal government has a number of initiatives that can help. Feel free to reach out to me if you have any questions about that, and I'm happy to take questions after Dr. King speaks. Thank you.
Dr. King, go.
Figure out this clicker. Oh no.
There you go. Magic.
Oh. Look at that. So the over the shoulder. Hi. You guys have some amazing endurance today, I have to say. Having just been here for a few hours, you have sat so patiently. I'm going to do an experiment. So I'm from Samsa, and that is our mission. We're going to practice the Samsa cheer, because if you remember no other thing today, I want you to remember my name, which is, I can go back, that, and how to spell Samsa, so you can send me an email if you have questions later on. So when I point to this side of the room, you guys are going to stand up. I know, prepare for this. No, I'm not even kidding, really, bear with me. Prepare for this. You're going to say S-A. Those of you in the middle, when I go like this, you guys are going to stand up from your chairs and say M-H. And then all the rest of you over here, don't feel left out. When I go like this, you're going to stand up and you're going to say S-A. I've never done this before, by the way. Does it show? Let's try this out. You guys bearing with me, right? You're so patient. I love behavioral health providers. All right, ready? This side. And it works backwards. Woo, Samsa cheer. Give yourselves a hand. That's also a little bit of dose of health for you, because we know that sitting is the new smoking, and you guys have been sitting for a long time. That's like 3 packs right there. So I may ask you to stand or do something or raise your hand, or anything that gets your blood flowing is really important, because our mission really is to reduce the impact of mental illness and substance abuse in communities across America, and that begins with you guys. That begins with your health. SAMHSA is a really small agency. How many people know the staffing of SAMHSA? Anyone know? Who believes it is like 6,000 people? Raise your hand. No, I don't see any hands there. What about 3,000? You think? About 3,000. No, what about 1,000? Do I hear a 1,000? I hear a 1,000 there. What about 600 or 700? Yeah, that's actually it right there, which is about how many people signed up for this summit. So we're a really small agency. Most of us are in the mothership in DC, except for 10. That's me. I'm here in Region 4. That's why I want you to remember how to spell SAMHSA, because if you have any questions about our agency and about how your tax dollars are being spent to advance that mission, I want you to email me. I work for you guys. That's why I'm here. Now, HHS has a 5-point strategy. Today, I'm not going to go into great detail about all the other things HHS is doing. Fortunately, we have one other person on the panel. I never before have had slides for a panel, by the way, so this is also very new and exciting for me. But I'm going to quickly go through what SAMHSA is doing to address the opioids crisis, and you're going to see how all of those activities that you guys have all funded fit into this overall HHS strategy, which is pretty cool. If I can get my clicker to go. All right, so in addition to our huge substance abuse and behavioral health block grants, which takes up most of Samsa's budget, mandated by Congress, they're non-competitive. We give out opioid-specific money, the SOAR grants, the STR grants. You can see we've given over almost $1 billion to states, given millions to tribes. But in addition to that, if you get these monies, boom, there it is, we'll give you even more money if you attempt to expand strategically evidence-based treatment. By evidence-based, of course, I mean MAT. And we've been talking about that a lot today, right? So if you're a state that has a high level of primary admissions for heroin or opioids, then you can apply for this first MAT PDOA grant, right? If you already have a strategic plan in place looking at prescription drugs and prescription drug misuse, then you can apply for this other additional funding, which involves an additional surveillance component, which is great. That's part of the HHS 5-point plan, right? So these are even like additional grants you can get on top of your federal grants, on top of the block grants. So we're taking your tax dollars and we are throwing it at the epidemic. If you're ever curious about it, we also support recovery services because treatment isn't everything, right? Once people get in recovery, we need to support that to the tune of about like 4.6 million. That's cool. And if you want to know where this is going, grants. This is the Samsa website. Click on that. You can click on View All Fiscal Year Grant Announcements and click, go back one. You can see all of the funding opportunities, which is fantastic, right? So you can see where the money's going. If you want to get even more specific, you can go and click on the map. You can click on your state in the map, right? And look at totals. And you can even see discretionary and non-discretionary funds and who's getting them. That's pretty cool, right? Anyone here getting some Samsa money? I know you are, Monty. Anyone? Raise your hands if you're getting Samsa money. Anyone? Yeah, I see some hands. That's fantastic, right? So you're probably on here somewhere, and that's pretty exciting. And we want to give you more money. Isn't that a great message? Everyone stand up who's had some training in administering naloxone. Stand up. That is fantastic. Stand up. Yeah, if you had training, go ahead and sit back down. Give yourself a pat on the back, right? And for those of you who didn't stand up, go ahead and get your calendar out and write a to-do, right? Seek out training, because why not? We've almost doubled our funding for this. Samsa is working really hard to advance access to and use of naloxone overdose reversing drugs, right? Advance. We also are increasing our funding for special populations, pregnant women, neonatal abstinence syndrome. We're doubling our funding there. We are also continuing our successful work with the criminal justice system to improve access to MAT, drug courts, right? Making sure that our grantees can use about 20% of their funding for MAT. We're working with diversion programs. In fact, I believe it was, if you combine fiscal year 15 and fiscal year 16, there were over 16,000 people who were diverted to SAMHSA-funded programs, which is fantastic. And then we're working with reentry programs to make sure people have access to care even before they're released, and a variety of other things. This is just a small amount. And because your privacy is really important, for the first time in 30 years, this happened back in 2017, for the first time in 30 years, HHS revised its regulations to improve privacy and confidentiality related to substance use treatment, which is really incredible, right? And so we're continuing to work with that so that you don't have to worry about your privacy or your data when you enter treatment. Now, because numbers are really important, I spent the last 16 years at CDC crunching numbers, and it's a lot of fun. I'm a nerd. Even if you're not into numbers, you should be excited about this. The National Survey of Drug Use and Health, right, has a lot of really interesting data. We published the 2017 barometer for the country, and this week, I'm told, I'm promised, it may be wrong, but I'm told the state barometers are being released. So sometime this week, you should be able to go and find the latest data from NISTA about your state, I hope. I hope I'm not a liar on that. But also, we have $10 million dedicated to the Drug Abuse Warning Network. Do you guys remember that? Anyone remember, Dawn? It was discontinued in 2011. Well, so this year, we have 25 participating hospitals. Next year, we hope to have 50. We're establishing it as a syndromic surveillance system, so it can truly detect almost real-time outbreaks, which is pretty cool. And I'm really excited about that because I think it's gonna do a lot of good for a lot of localities. Real-time data, really fast, as opposed to NISTA where you have to wait 2 years to find everything. And we all know that since 2017, a lot has changed. So as much as I love NISTA, it's just so darn slow, right? So one other way that I really like that we're spending our money, we funded the Opioid Response Network, which is really the American Academy of Addiction Psychiatry and 27 partner organizations. And they will provide you 24-hour responses to needs for training and education, right? And there's a little send a request button right there. It's a really short form. You fill out who you are, what training you need, what your questions are, and within about a day you get a response. So these are really targeted local providers who are going to provide answers to this information. That's very exciting to me. If I could advance that. Save the best for last. We have a nationwide network of technology transfer centers. This is the map of the Addiction Technology Transfer Center, very relevant for this audience today. But here in Region 4, we're super lucky. We have 3 different kinds of technology transfer centers, right? In addition to the ATTC, we have the only mental health technology transfer center situated in a school of public health. And that's pretty important. Population health, public health, dealing with populations, not just individual risk factors, that's a whole different perspective. And then, of course, we have the prevention TTC. Some of these people may even be here today. I know the top 2 aren't, but maybe Mark is somewhere. I don't know Mark yet, but he might be here. So, take your phones out. Take a picture of that. I want everyone to have this information, seriously. How often does the speaker say, get your phones out and take photographs, right? That's really important. And I'm sure you'll get these slides, but I don't want you to wait. I want you to be able to go ping these people today and say, what have you got for me? Now, resources. I brought along, because I radically underestimated the number of people here. I thought it was going to be this small little panel, intimate, close. You know, I printed up, like a handful of some flyers, resources that look like this. I have a small stack of these, with a lot of words on them and a lot of, links like that. Afterwards, if you want to come grab some of those from me, I'm going to just leave them maybe on your table right here, sir, and then you can have other conversations with everyone. But if we run out of paper, they're online. We have all of these resources online. If you haven't been to this website, take a picture of this too. This is the free stuff, by the way. I just want you to know, you've paid for all of this, right? You paid Samsa to develop the best resources possible to advance all of our mission. And this is where it all lives. And it's free. You can go get it. One of the best resources here is this, the treatment locator. And I love that you mentioned that because this is super key. And if you had this overlaid on that map, woo, how powerful is that? What a great conversation you could have with a client, right? Like, look at this. You've got 3 different options. Anyway, I think that's really neat. If you want to learn a little bit more about OUD, free courses online, continuing education credits, totally free, your tax dollars at work, right? Or you can download the opioid overdose toolkit that we've developed, which is huge, right? Be careful when you're printing it out. You may just want to do the electronic version first. But this is a great foundation for having conversations with communities who want to do something different, with providers that want to do something different, with families that are dealing with this. Although it is pretty dense, you may have to unpack it a little bit for them. We have a couple of new publications. If you're a provider, our treatment improvement protocol is super recent, super up to date. It's also a really big book. You can email Samsa, we can send those to you, or you can just download it and look at it electronically. Also, pregnant women, right? Really important, really timely. Go ahead and check those out. They're very new. We have an iPhone app. Sorry, Android users. But I also apologize to our iPhone users because apparently this wasn't working recently. So I'm putting it up there because I'm really hoping that they get all the bugs worked out. It's advertised on our website. Again, I am new to Samsa, and I take no responsibility for the functioning of this iPhone app, but it's very exciting that they're packaging it that way. For the old school people in the crowd, we have a pocket guide made of paper that you can order, right? So yeah, it doesn't matter what operating system you have, paper still works, and it tucks right in your coat and has all the same information as that lovely online app. Now, if you're working with somebody who has no idea what treatment option they want, we have a publication which can decipher that for folks. So if you work with people who regularly have to make these decisions, and maybe even you yourself aren't up to all the latest and greatest on treatment options, this publication is for you. I mentioned numbers before. We publish all of the NISTA stuff in a really big book. I don't find that super useful, maybe you do, but those barometers you need to go look for because those package the data in a way that makes it useful information, right? Data are great, information is better, and then information in a way that leads to action is the best, and you guys are the ambassadors of that. You have to be able to use it. Finally, SAMSA and NIDA partnered with the National Academies of Science, Engineering, and Medicines. I always forget, is that right? Yeah, Science, Engineering, and Medicine, to compile the evidence base for MAT. So now there is absolutely no doubt. There is strong evidence that supports MAT and to show that it saves lives. It's the standard of care. If you're not doing it, if you're not referring people to people who do it, then you're behind the times. I'm sorry. And we could talk a lot about barriers to evidence-based practice here, but the science is there. Science isn't enough, though, right? It's not enough without people who can communicate it in a way that gets through the stigma, that gets through the cultural barriers, that gets through the preconceived notions and the negative opinions, that gets through years and years of habit, right? And that's all on us. That's our job. That said, that's what I have for you. That's my show and tell. Let's try the Samsa cheer one more time to make sure you guys remember. Because remember, if you remember nothing else, I'm here. I work for you in Region 4. Let's go to this side of the room. Stand up and say it. Let's do it backwards. Woo! Thank you, guys. That's the wave.
We like to wave in Knoxville. I don't know if you have ever spent an afternoon watching the University of Tennessee play football just down here on the river, 100,000 of our closest friends.
Oh, wow.
Yeah, you need to come up and visit. I think we've already talked about that, right?
I'll do it.
Yeah, so we, as you can tell from Betty Ann and Captain King both, incredible knowledge base here. So we do have about 5 minutes or so for questions from either of our panelists. Yes, ma'am, I see one over here.
Hi, Rebecca Parr, Next Step Initiative. I'm curious if there's funding and data being collected about the future of what we're looking at with the NAS children, as well as into our public school systems for educating teachers and our stakeholders there as to what's to come and what they're dealing with now.
You got the question, right?
Is that for me? So I will tell you, I am on week 4 of working for SAMSA. So unfortunately, I'm not the greatest resource for everything that SAMSA is doing. I know that we collect data on treatment episodes. We collect data through NISTA on a number of different issues. I would actually have to look that up. I don't have that answer right now. But I have the websites where we could all look. We could, pull aside and poke around. And that's the beauty of these online resources. I may not have the answer to your question right now at the tip of my tongue. And that's okay, because I know where to direct you to get those questions.
Let me, so if I could jump in. So I am on the SAMSA, SA Advisory Committee for Women's Services. And so we just, and I love it. And so if you report me back to the top office and I get this wrong, so be it. But I think I'm right. And it's, of course, as you can tell by the additional funding, it's very important to SAMSA and the federal government. But there are studies. I think the only thing that can truly be said right now about long-term harm to children is that we don't know. However, the studies maybe lacking in part as they might be, suggest that there are. And Dr. Matt Harris told us earlier referred to I think the Tennessee Department of Health study that showed that there is cognitive delay. There are social interaction challenges for those children that don't manifest until they're 7, 8 years old. There are studies that are continuing to track these children, ongoing right now, I believe. But I think the short answer is there's no definitive study that answers that question But the data is being collected. I know it's being collected in Tennessee. They've been following for a good, I think, 8, 9 years. Is that, would one of you two know, Dr. Pack? So the Dr. Pack's statement was that 16,000 plus records of those babies digging into those, but I'm not familiar, and I think Dr. Saunders, you'd know if there was some current study that's been published. All right. So Dr. Saunders said that our Tennessee Department of Health study is the most recent and illuminating, and that is on their website. So that study showed children, 7, 8, 9 years old? Yeah. Good question. I'm sorry.
Thank you both for what you do for the rural communities and for SAMSA. Mark Rapay with Spiro Health. Last October, I believe, the Support for Patients and Communities Act of 2018 was enacted. Part of that is to move MAT providers who don't have to wait a year to get to 100. Hearing today, access to quality MAT providers. As we stand today in August, our providers can't increase to 100. Can you give an update on when that might occur?
Well, no, I can't.
Fair enough.
I know. But what I can tell you is that there are a number of different agencies currently working on this issue. How do we expand evidence-based treatment, and how do we take away some of the barriers to providing that kind of care? So I know that SAMSA's priority has to do with eliminating payment barriers. So I think I've heard this mentioned a couple of times, the idea that we want to get rid of the pre-approval process for things like behavioral health or MAT. We want to get parity. We want to make sure that reimbursements reflect the true cost of treatment. So I know that there are a number of initiatives underway that are cross-cutting, not just with SAMSA. So I know that we're partnering with CMS on the reimbursement process. We're partnering with DEA on practice standards. I don't have the answer to your question. I think it's a fantastic question to raise, and I think it probably hasn't been answered, because if it had, you would know about it. Yep. Yeah, and welcome to government work. So all I can say is that
Mic's not working. Thank you, Captain King. So I think that we have time for one more question.
Hi, my name's Addie Arback. I'm from Next Step Initiative also. My question is, first of all, I want to thank SAMSA for all the grants you put out there, because we work with homeless people, so we use you guys a lot. Thanks. My question would be, we all know that this is a disease. We all know that you could do so much time and come out and fall. so much time come out and fall. Do you ever think about maybe, or have you thought about putting some grants towards the aftercare? Because it seems like that's the worst part, is when they first get out, they don't have anywhere to go. And if they could do aftercare, like maybe putting grants towards halfway houses and things like that, do you think about that? I know that Jason Goodman, yay, has a program, but there aren't a lot of that going on, and I wonder if you guys are thinking about that.
Sure.
Working. All right. So because I'm sitting up here with Betty Ann, I'm going to take this moment to highlight an MOU between USDA and Samsa, which is specifically targeting recovery housing. So selling, refurbishing foreclosed properties for recovery housing. And you saw that dollar figure for fiscal year 19 that increased for recovery support services. And, that obviously didn't capture all of the picture. Things like federal to federal partnerships, where we're working to create the environment that supports recovery, that supports health. Because I love the quote from earlier today: the opposite of addiction is not recovery, it's community. And that's absolutely true. So economic development in communities, investment in communities, safe, healthy homes, people having futures that they're excited about, that's the opposite. So that's just one example of where we're going.
But Ann, do you have some follow-up with that?
Sure. Use your mic. So to his point, and again, always my perspective is rural, so I apologize. But we, obviously through USDA Rural Development, we do a lot. We do single-family homes, multifamily homes. We construct from scratch, and then we redesign and build. But our money is no good if you're not rural, so that's the caveat. We also, to the MOU he referenced, the reason why I mentioned that we're single-family and multifamily part is because we own a lot of property. USDA is probably the second largest owner of property in the United States in rural communities, because again, we do single-family and multifamily homes. So what happens is, if there is a foreclosure, we'll have a property on our books. And the Secretary had asked us last year to think about how that could be repurposed, if possible, to help in the fight. And one of the things we explored, again, this is not to say that these homes are actually in areas where services are, but we do kind of say, hey, these homes are available, and leave it up to the potential for everyone else to look to see if they could potentially provide what you're thinking about. And of course, you deal with the zoning issues and the local issues, because these are single-family homes that are vacant. And so we give a window where folks can look at if that could potentially be repurposed to help. So again, from our perspective, you can do new building, redesign, or repurpose something that's old. So there are some options out there, and a number of different agencies are working together to make it available. Again, this is where I bring in the private sector needs to be a part of this conversation. When you get into that housing space, that's a capital intensive of work. It's very hard to do anything with just grants when it comes to housing. So the housing stakeholders that I tend not to see at the table need to be kind of flagged in, and the community banks and all those kind of local folks who are thinking about this to help you think about what could be a recovery housing, how they can help in that space.
Yeah.
Happy to talk offline about that if you have questions.
And our Creating Homes initiative, am I saying that right? That we have here in Tennessee. I mean, and that's the vision, right? Is to use the $3 million as seed money to pursue other opportunities and leverage other opportunities. And we've already THDA has already matched the $3 million. Captain King, do you have something you wanted to add to that? Okay, great. Well, thank you, panel, very much. 15-minute break, and we'll be back. And Dr. Pack.